Month of Sepsis Awareness. So, to begin with, let us see the burden of sepsis worldwide. Sepsis is a global health crisis as it affects 47 to 50 million people per year overall the world, and at least 11 million people die every year due to sepsis. There is 1 in 5 deaths worldwide which is associated with sepsis. And sepsis is the number one cause of death in hospitals, and it is number one cause for hospital readmissions, and it is number one cause for the healthcare cost. And up to 50% of sepsis survivors suffer from long term physical and psychological effects. 40% of cases are children under 5. And most important, 80% of cases occur outside the hospital. Sepsis is always caused by an infection like pneumonia or diarrheal illness. Sepsis is a medical emergency as every hour counts. When you look at the burden of sepsis in India, almost 11.3 million cases account for sepsis, and among this, 3 million deaths are due to sepsis. So it's a quite a lot burden, and it is second only to the cardiac and neuro cases. So that is why here we are today to fight against this sepsis, to make ourselves as physicians aware of sepsis, and also to make our patients aware to how to prevent sepsis and how to deal with the consequences. So let us look into it. What is sepsis? Sepsis is a life threatening organ dysfunction due to dysregulated host response to infection. This looks sophisticated and very complicated to you, I understand. But to make it simple, sepsis is just a response to an infection which is very overwhelming and which is very life threatening. So it's just a response to infection which is erratic response of our immune system. To know the cause of sepsis, most commonly sepsis is caused by bacterial infections, but it was also caused by virus, parasitic, and fungal infection. Like you have seen the pandemic, like COVID-19, that is the cytokine storm. You've all heard about the cytokine storm. That is nothing but viral sepsis. Yeah, and the sources of sepsis, most common sources of sepsis are usually the lung, which is most commonly the pneumonia. The second most common is diarrheal illness, which is from the gut, and the other causes are meningitis, skin and soft tissue infection, catheter related infections, urinary tract infections, and bloodstream infections, abdominal infections due to appendicitis, gallbladder infection, and diarrheal illness. There is also an infection of unknown sources in few cases. So, generally, when we have a healthy immune system, the immune system helps fight all the bacteria, virus, fungus, and parasites in the best way with the balance of inflammation and pro-inflammation and anti-inflammation. This is in a normal, healthy individual. So the balance is maintained, and finally, the macrophages and the inflammatory mediators take care of the bacteria. But in a case where sepsis is predominant, like in few cases, but sometimes our immune systems escape this control and they become erratic and disorganized, and this is the start of sepsis. So when you look at the cascade of sepsis, so primarily there is a source of infection either in the lung or in the gut, and when this infection bacteria enter the blood, there is start of sepsis like endotoxin release. Usually it releases the inflammatory mediators which causes the capillaries to leak. Because the capillaries leak, all the fluid inside the blood vessels leaks out, and it causes hypotension. And the second cause for hypotension is due to the vasodilation, which is caused by the endotoxin. So there is another problem occurring at the same time, that is the activation of coagulation pathway, that is microthrombi in the microvascular circulation, that leads to organ dysfunction. Usually there is cardiac dysfunction, renal, liver, then ARDS, lung, then you have encephalopathies, and finally leading on to death. So this is the cascade of sepsis, septic shock, and then organ dysfunction and death. So this is a really a medical emergency, and it has to be tackled very early by early identification, diagnosis, and treatment. So it's a medical emergency. We call it a medical emergency because the risk of death increases 4 to 9% for every hour the treatment is delayed. That in every hour the antibiotic administration is delayed, the risk of death increases 4 to 9%. You can understand the intensity of the severity of sepsis only by this statistic. And suppose, like, if you consider, like, normally a patient comes with a chest pain, the family and the doctor know the sensitivity of the situation and intensity with which they have to deal, because they know that time is muscle. Similarly, brain stroke, time is neuron, so they rush to the hospital and then get the treatment. The same intensity should happen with sepsis, because the mortality with every hour delay is increasing. So that is why here we are today, to fight the sepsis and to make people aware of the urgency of the situation. So, to tackle this, we have to know who is at risk, know the risk, then spot the signs, and then act fast. So, this is the get ready to fight sepsis advised by the CDC given this September. So, for this, we should know who is at risk of sepsis. First, age more than 65, people with weakened immune systems, people with chronic medical conditions such as diabetes, lung disease, cancer, kidney disease, and also the liver disease, people with recent severe illness or hospitalization, and people who survived sepsis, and children younger than 1. These are the high risk population. Sepsis can affect everyone, but you have to remember this group to target it easy when patients come to you. Then you have to spot the signs and symptoms for early diagnosis. So first, the signs of sepsis, signs and symptoms of sepsis. High heart rate, there will be weak pulse, there will be confusion or disorientation, extreme pain or discomfort, fever, shivering or feeling very cold, shortness of breath, and cold and clammy and sweaty skin. So these are the signs which you can recognize that patient is in sepsis. So there are other scores, like you can ask, how can we differentiate a normal infection versus sepsis? So you can ask me that how to accelerate the process, that how will I know that this is a sepsis patient and not a simple infection. So this course will help you in dealing with this situation. Like if a patient is with suspicious infection, then usually you calculate a score called systemic inflammatory response syndrome scores. You need not remember everything about it, just remember that it has 4 parameters, and if more than 2 parameters are raised, then it is a sepsis. So temperature more than 38 or less than 36, heart rate more than 90, WBC count less than 4,000 or more than 12,000, and respiratory rate more than 20 breaths per minute. These criteria in all these four, if two are raised, like temperature is raised, suppose heartbeat at around 110 or 120, then you can label this patient as likely sepsis. So you will have a overall idea that you are dealing with a sepsis, and you have to accelerate the process of initiating the antibiotic as early as 1 hour. So the other score which the recent sepsis guidelines has incorporated is Q SOFA score. Q is quick, SOFA is sequential organ failure assessment score. So if more than two criteria in these three parameters, that is systolic blood pressure less than 100 and respiratory rate more than 22 and altered mentation, if the patient is in hypotension, if the patient is tachypneic, and if the patient is drowsy. So you'll get an idea that this is a likely sepsis. Then you further assess the complete SOFA score. and then label him as sepsis. So till now you have come to the diagnosis, like clinical diagnosis, you have confirmed that this is a septic case, right? So now how will you manage it? So if you are equipped, if you are in a well equipped center and you can manage the sepsis well, then you can straight away start the treatment with IV hydration and everything. But if you are not well equipped, then early referral to a tertiary center is mandatory. So for this, the sepsis, surviving sepsis guidelines has given us the 1 hour bundle. So as soon as there is sepsis or septic shock, then initiate the 1 hour bundle. In 1 hour bundle, you have first measure the lactate. So as soon as the patient comes, take a venous sample or an arterial sample and then measure the lactate. Okay, and then second step is obtain the blood cultures before administering the antibiotic. Two sets of blood cultures from both the hands, from both the peripheries. If there is a central line, then one from the periphery and one from the central. So obtain the blood cultures before administering the antibiotics. Then the third step will be administer broad spectrum antibiotics. Then fourth step will be begin rapid IV fluid administration. That is, according to the guidelines, it is 30 ml per kg crystalloid for around 3 hours for hypotension, or if lactate is more than 4 millimoles per liter. But this doesn't stand in all the cases, as you have to take care whether patient is a cardiac patient or not. If the patient is a cardiac patient, then with 30 ml per kg of crystalloid, he will land in pulmonary edema and it will worsen the situation. So if even though the guidelines mentioned it, there is a asterisk over it. So the fifth step is, now you have given the fluid, the PP is not picking up, then you have to start noradrenaline as soon as possible. Apply vasopressors if hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of 65 millimeters of mercury. That is MAP of more than 65 millimeters of mercury. So this is the 1 hour bundle, and then in the last you have to re-measure lactate if initial lactate is more than 2 millimoles per liter, and this will complete the 1 hour bundle. So this is the urgency and the immediate treatment which SSC guidelines have given us to maintain the to treat the sepsis and to diagnose it, to treat it and act fast. This is the act fast regimen that everything should be completed in 1 hour bundle. Then, if there was a controversy regarding the antibiotic timing, which the recent sepsis guidelines have made it very clear that there are two scenarios, as you can see here. One is, in one case the sepsis is definite, that you don't have any doubt that this is sepsis, and the shock is present. Then you have to administer antibiotics straight away within 1 hour. There is the other possibility that sepsis is possible, that you are not 100% sure that this is sepsis. But still, if the shock is present, you have to administer the antibiotic within 1 hour. So, irrespective of sepsis is definite or sepsis is possible, you have to administer antibiotic within 1 hour of recognition if the shock is present. So, this is clear cut. The second scenario is, there is sepsis is definite or probable, but the shock is absent. But you are sure that sepsis is definite, then you have to start the antibiotic within 1 hour. There is second ambiguous situation where sepsis is possible, then shock is absent. Then you are in a dilemma now that you have to give antibiotic or not, whether it is a cardiogenic shock or whether it is an anaphylactic shock. You need time to decide which shock it is. So that's why you need to do a rapid assessment of infectious versus non-infectious causes of acute illness. And then after this rapid assessment, you have 3 hours of time to administer the antibiotic. And within this 3 hours, if you think that sepsis is possible in any way, then straight away administer antibiotics. So this is regarding the antibiotic timing. The second controversy comes when there is hypotension, the patient is not getting improved even after multiple fluid boluses, and the hypotension is not improving, the blood pressure is not improving, then comes the role of vasoactive agents, that is noradrenaline. Many of us have doubt what is the choice of vasopressor in septic shock. So the choice of vasopressor here will be norepinephrine is the first line drug. And you see the green ticks, these are the grade 1 recommendation, that is very strong recommendations from the surviving sepsis committee. So this should be followed, like this is the strongest recommendation and this should be followed. The other triangle with an exclamatory mark, this is a weak recommendation and you can follow, you cannot follow, and it is up to your facility. Like if you are well equipped, then if you are well equipped you have to follow, if you are not well equipped then you can disregard this. So the other recommendation is target a MAP of 65 millimeters of mercury. You have to increase the NORAD, decrease the NORAD, and based on the MAP, mean arterial pressure, you have to decide a particular dose of noradrenaline for this particular septic shock. So the other recommendation is invasive monitoring of arterial pressure. Some centers tell it is mandatory to put an arterial line, but in a low resource setting like ours, it is not always possible to have the equipment dealing with the invasive arterial blood pressure monitoring. So you can or you cannot. So there is uh, a concern for vasopressors administering peripherally. Sometimes, in a low resource setting, you can omit inserting a central line immediate at the onset of receiving the patient. You can put noradrenaline at a low dose for some time in the peripheral vein, ideally in the antecubital fossa. You should not wait for inserting the central line to initiate the vasopressors use. So, this is the main idea of this. So consider adding vasopressin if the shock is not resolved with noradrenaline. So consider adding dobutamine or switching to epinephrine if the shock is also due to the cardiogenic. Sometimes there is a septic component, sometimes there is cardiogenic. So both together when they occur, despite noradrenaline, if the BP is not improving, then you can consider adding dobutamine, but not dopamine as many of us add. So if first choice is noradrenaline, second choice will be vasopressin. Then after this also shock doesn't resolve, then evaluate for the cardiac causes. If the cardiac cause is found, then go for dobutamine rather than dopamine. If dobutamine is not ideal because of arrhythmias and all other issues, then you can go for epinephrine. So this is the overall guide. So, how can we prevent sepsis? First step for prevention of sepsis is spreading awareness. Spreading awareness among the healthcare personnel like physicians, primary contact physicians, PHC physicians, and also educating the patients and families. Educate your patients and their families about preventing infections, keeping cuts and wounds clean and covered until healed, managing chronic conditions, and recognizing early signs and symptoms of sepsis, and seeking immediate care if signs and symptoms are present. So, prevention of sepsis first is awareness, then intake and utilization of a clean water, then hand hygiene, prevent hospital acquired infections like ventilator associated pneumonias, central line associated bloodstream infections, and urinary catheter associated UTIs, and surgical site infections, and safe childbirth and vaccination to all vaccine preventable diseases like influenza, chicken pox, you have COVID vaccines, and typhoid vaccinations. All these, for all the vaccine preventable diseases, you have to encourage people to take vaccinations. Then the CDC recommends the four ways to get ahead of sepsis. That is, first is prevent infection by taking care of chronic conditions and vaccinations. Second is practice good hand hygiene, know the symptoms and act fast. Sepsis is a medical emergency and time matters. September is Sepsis Awareness Month. Stop sepsis and save lives. That is the concept. And thank you for giving me the opportunity.